So I'm going to talk by walking so that I make every PG to ask some questions in nutrition so that we'll make the session very livelier. So I will come each and every, that's why I'm going like this, what Dasavadaram Kamalasan is doing. Okay? So this topic was named as nutrition rehabilitation. You know what is rehabilitation, no? Rehabilitation means there's nothing there, that is the end point. There are some diseases where only nutrition is going to cure, not your drugs, nothing is going to act for them. Okay, so I will give you the simplest form of approaching here. This is how you can plan the nutrition. It is not like your beta showroom price like 99.99999. Don't remember all those things. Let us remember simply what we can apply for nutrition. No? This is my institute, ICH, my famous institute, where you can see small things. Those are all the slides which is present. Each and every department is there. So I will show you the first department. No. Yes, it's an intensive care unit, the first department, no? Unfortunately, many intensive care units you are worried about. So far in the morning you saw dopamine, dopamine, epinephrine, norepinephrine, ventilation, ECMO therapy, all those things. But everybody has forgotten the nutrition, okay? How many of you tell in your units that day one you are starting nutrition in a sick, unconscious child? Please raise your hand. Don't raise your hand. You are starting day one. So any unconscious child. So I will give you the details why IMCU child you should start nutrition on day one of life. Because after all your antibiotics or ventilators, everything is going to maintain the life of the child. It is not going to improve the life of the child. If the child's life has to be improved, nutrition should be there. Okay. So let us see. This is the most famous picture. See what many studies have proven that in a PICU, 45 to 50% of the deaths is prevented by nutrition. If you are not giving nutrition in a PICU, there is a delay in discharge, delay in recovery, increased mortality and increased morbidity. Okay? So let us plan how we can put nutrition in a PICU child. No? So see this figure. This is a very important diagram. Have it in your mind. See? You can see in any children when they are really sick, there is two things is there. One is called catabolism. Number two is the metabolism. Okay, catabolism means all the three things will get disintegrated, like your lipolysis. There is a breakdown of protein and the glycolysis. This glycolysis will release glucose that will be utilized by the liver. The lipolysis will release some fuel. The brain will take the fuel for brain. Then the protein degradation, the amino acids is taken care by the liver. Once the catabolism is over, then comes the metabolism. Okay. In metabolism, there are two phases. There is a slow metabolism, there is a fast metabolism. What they say, it's called F phase and flow phase. F phase means the metabolism has started, but the cardiac contractility is not that much, oxygen utilization is not that much, enzyme is not that much active. That is the F phase. When I say flow phase, everything is increasing. Oxygen consumption is increasing, cardiac contractility is increasing, enzymatic activity is increasing. Okay? That means this is the stage. If you want to substitute these patients with nutrition, this metabolic phase will get enhanced. So that even though the child loses weight and loses calorie energy by catabolism, when you support this child during the metabolism, the child will improve in his weight, the child can get adequate calories and proteins. That's why nutrition at this critical juncture. There are studies only in adult that the supporting the metabolic phase with nutrition will improve. There is no studies in children, but it has been understood that even in children, if you start giving fuel, if you start giving nutrition at this phase, the recovery, the mortality, the morbidity, everything is going down. Okay? So this is an important picture. You can see the liver, after getting all these things, finally it releases the proteins. This protein is called repair. For repair you need protein. For example, I'll give an example. So far you are discussing about bronchiectasis, no? You talked about bronchodilators, physiotherapy, dilatation of the bronchi, arterioles, okay? There is a damage in the lung, okay? Suppose you have a damage here. Then how the recovery will come? Do you think your antibiotic is going to give the recovery? Do you think your oxygen is going to give recovery? Do you think your IV fluid is going to give recovery? No. The nutrition is going to give recovery, okay? That means in a sick child in a PICU, day one nutrition is mandatory. Which PICU which is going to practice nutrition on day one of life, the outcome is going to be really good. Okay. So let us see. I told all this about. Let us see how we can do. One case scenario I am giving. So I am going to call one person. This fellow, Arun. Okay. A 10 kg child. Please stand up. Give him a mic. A 10 kg child with MPEMO on ventilator. Okay, the child is on ventilator. He is very severe respiratory distress. Okay, but his gut motility is fine. So that is the only point I want to examine as a nutritionist when the sick child is there, whether the gut is fine or all right. If the gut is fine, I am not bothered about the heart, I am not bothered about the brain, I am not bothered about the respiratory system, because my gut is fine. My job is to take care of the gut, not the other three. So I will start the nutrition when my gut is free. So day 1 of life in PICO. Okay, Arun, 10 kg child, how much calorie you want to give for this child? So he said, according to the Holiday and Segar formula, I will give 1000 calories for this child, right? And LIC madam was telling, no, whenever there is increased hyperventilation, you have to give 10% extra calorie. So you can say 1100 calories or something like that, okay? So he is going to give calorie, okay? Now, next, CB, are you confident in starting nutrition on day 1 of life fully? Will you start, or you are slightly hesitant? Put your hand over the left ventricle and tell.
Slightly hesitant.
He is standing is also hesitant also. So he is slightly hesitant. Okay. So for CB sakes, what I am going to do, I will give 50% as IV fluid and 50% as nutrition to be on the safer side. If the child is all right on the first day, then the next day I will go for 100% nutrition. Okay. Okay. Sit down. Divya, what fluid you want to give? Or let me ask, which fluid has got a wonderful calories out of so many IV fluids? Out of so many IV fluids, which fluid has got wonderful calories? I will give an option also. Normal saline, 5% dextrose, 25% dextrose, isolate P.
Isolate P.
Isolate P will have only 5 grams of glucose. 25% dextrose will have 25 grams of glucose. So what is the best fluid then? 25% dextrose. Okay? Sit down. Sanjana, can you give 25% dextrose peripherally? No. So what is the percentage you want to give in the periphery vein? 12.5. That means I have to dilute this 25% dextrose. Okay. So take this as an example. Take 3:1 ratio. Take isolate P as 3 and 25% dextrose as 1. Because many studies have proven that isolate P is still a good IV fluid because it contains sodium, it contains potassium, it contains 5 grams of glucose. Your normal saline did not contain 5 grams of glucose. So from the nutrition angle, I would have preferred a isolate P rather than a normal saline for this kind of children. Because it contains 29 sodium and 25 potassium. That means my fluid is going to be 3:1. That is 375 ml of isolate P, 125 ml of 25% dextrose. If you mix like this, the percentage in the periphery will come down below 12.5. So you can give boldly 25% dextrose with isolate P. That is going to be the fluid. So I said this is a child of 10 kg. I am planning a 1100 ml fluid. That means 550 ml is going to be isolate P with 25% dextrose. Remaining 550 ml is going to be nasogastric feeding. Okay? You are worried. The child has got a cleft blood palate. Child has got a delayed emptying. Child has got a GERD. Child has the tendency to aspirate. Go for orovaginal feed, not orogastric feed. That means nostril to tragus, tragus to xiphisternum, xiphisternum to the anterior axillary, you reach the jejunum. Okay? So orovaginal feed can be given. So any child in PICU, see, this is what we are going to plan. That was I was discussing so far. This is going to be the plan of management in an ICU child. Any child, if the gut is all right, whether it is status epilepticus or cardiac failure. But one thing you should remember, you have to adjust the fluid according to the system. Suppose I have a cardiovascular system, my fluid is going to be 2/3. If I have a renal system, my fluid is going to be 2/3. If I have got a liver system, I have got a respiratory system, what is the normal required fluid? I will go for it. Regarding the protein, if it is going to be renal system, I am very hesitant to start not more than 0.5 to 1 gram. Suppose it's a cardiac, I go for 2 gram. If I got liver, I go for vegetable protein, not animal protein. Vegetable protein I go. If it is lung, was discussing, 2.5 gram. Even I go to 3 gram per kg also. In 1970s, 80s, there is a diet called TB diet. The TB diet is full of protein. Every hospital was supplying. Now no hospital is supplying because they felt that nutrition during the TB days will clear many cavities and many fibrosis and many collapse. So nutrition was given importance in the 80s and 90s, not in 2010 and 2020. That is very unfortunate. We'll go to the next slide. So these are the common fluid everybody should understand, no? What is CPP kanji? What is egg fillip? Egg fillip is nothing but milk with egg. 150 ml of milk with 1 egg will give 10.5 grams of protein. See, these are the fluid. You remember, everything gives 200 calories. Some examiners ask you, 200 ml water, 2 orange, 2 teaspoon sugar, 200 calories. 150 ml milk, 1 egg, 1.5 teaspoon sugar, 200 calories. High energy milk, 200 ml milk, 2 teaspoon sugar, 1 teaspoon oil, 200 calories. So remember, these are all 200 calories where you can employ in an ICU setup. Okay? Okay. The next department I will go is diabetes department. Very important. Okay? All the PGs are worried about the sugar. I am worried about the figure. I am not worried about the sugar because, yes, I am worried only about the figure because I am seeing in my ICH so many diabetic children with insulin. Not one child is looking pretty. Unfortunate because nutrition has not been given importance. So what I do, you see the sugar, give the insulin and advise the diet. What I am going to do, I give the diet, increase the sugar, give the insulin. Just ulta. So what I want to plan now, that is called Dane concept. What is Dane concept? Dose adjusted against normal eating. This is what Western world are practicing. Dose adjusted against normal eating. You allow the child to eat normally, not necessarily alwa and other things. Normal protein diet. Then you see what is the glycemic response. Then you plan insulin. That is the plan for diabetic diet. So our aim, what is our aim in diabetic diet? The glycosylated hemoglobin should not be more than 7.5. The fasting glucose should be around 90 to 160. The postprandial sugar should be 100 to 180 for toddlers and for 12 years. This is what our aim in maintaining the sugar. Okay? Okay. Now, nutrition guidelines. Next, how you calculate the calories. Don't go by holiday and cigar formula. Holiday and cigar formula, உயிர் வாழறதுக்கு. It is not for improving your health. It is a maintenance fluid. So it will not help if the child is growing. You have to go increase. What the Western literature says, for men, it is 125 kilocalories per kg. For women, it is 100 kilocalories per kg. That's what they decide for diabetic. How they calculate also. First 1 year, you give 1000 calories. Then according to the age, you can multiply. For example, for a woman, I am giving a diabetic child, a 7-year-old child, 1000 plus 7 into 100, 700. That means the total calories planned is 1700 calories. Next, what is important? How to give this food? Divide the food for 6. I am a diabetic, I take 6 feed every day. I am a diabetic, I take 6 feed, You say breakfast, lunch and dinner, mid-morning, mid-evening, midnight snacks. Fine. 6 feed is there. Midnight snacks means in the form of milk. Not I am not going to take vada in the midnight. It's the form of milk, I say snacks. Okay? Mid-morning, mid-afternoon. So every child should have a 6 diet. You should not compromise in this. Okay? Now, let us calculate one child. Okay? Again, I want some volunteer now. Who is my Mani Bharati. No, he is next to me in ICH, in nutrition expertise. Where is he? Stand. 5-year-old diabetic child, weight 14 kg, blood sugar 340. Okay? Total calories I have planned is 1625. Okay? Now, Mani Bharati wants to divide the 1625 calories into 6 parts. See, the idea is have equal calories so that you will not fluctuation. What we do now, tell me, morning we eat less. That is more important for our brain breakfast, but we are not taking. But night we eat fully. That is very unfortunate. So diabetic children should have a diet which is almost equal so that the calories are not getting turbulent. It should be very smooth sailing, So 1600, what I do, I give maybe 350 for breakfast and lunch and dinner, 200. You cannot take 400 calories for snacks. That is very important, very not practically possible. So we will have 200 calories for snacks and 350 to 400 calories for the diet. Okay? So we are breaking into 6 diet. Okay? Now Mani Bharati, I want to give breakfast, say 300 calories. What are the food you want to advise to the baby? What are the food? Tell me. You can plan anything. Okay, 300 calories for a child.
Breakfast. 100 ml milk.
You want to give 100 ml milk. So he is giving 60 calories milk. Okay.
Without any sugar.
Oh, okay, right. Breakfast.
Three idlis.
He wants to give 3 idlis. That means 150 calories. 210. Fine. So 150 plus 60, 210 calories.
with sambar, with added ghee.
So you want to have 1 currency of sambar, 50 ml of sambar, that will contain 2 teaspoons of dal, that means 1 gram and 20 calories, and little bit of vegetables. I will give vegetables as 25 calories. That means 20 plus 25, 45, 210 plus 45, 255 calories. I know you are all very weak in mathematics, but I am very good in mathematics. Okay?
Plus added extra ghee.
So you want to give 1 teaspoon oil, 40 calories. That means he has reached 295 calories. So Maniparthi, what he has given a diet like 3 idli, 100 ml milk, 1 currency sambar, 1 teaspoon of oil or ghee, whatever it is. He is reaching 300 calories. Okay. Now you have to plan insulin for this child. You have to plan. Now I should know this 3 idli, oil, milk, how much it is increasing the sugar. Correct? That is called glycemic response. No? Then what I am going to do, this is called carbohydrate counting. I am going to count the carbohydrate counting. Very simple. All your cereals, idli, dosa, whatever tiffin, 100 grams gives 15 gram. Okay. All your pulses and milk gives 12 gram. Okay. All your vegetables give. So remember the 3 numbers: 15, 12, 5. 100 grams, 15, 12 and 5. All your 100 grams. Okay. Now, how many of you have measured diaper in acute renal conditions? Please raise your hands. Raise your hands. How many of you have measured the urine? Fine. How many of you have measured idli? Only one fellow has measured idli. This is very unfortunate. Now, if you are measuring the diaper, what is the weight of the diaper? When they pass you, normal weight of the diaper, 15 to 18 gram. So, you measure the idli. It may be a Kanjipuram idli or maybe a Saravana idli. Kanjipuram idli, you can break the head. That's such a powerful idli. No? Saravana idli is very light. Yesterday night, no, that is called Yelani idli, coconut idli. Yesterday night, no, you have tasted. That is very light. Maybe 10 to 15 grams only. Okay. You measure the idli in such a way that how much gram. For example, I'll tell you, he said 3 idli. Okay. I'll take this each idli as 50 gram weight, digital weight. So 3 idli gives how much weight? 150. The idli weight is 150 gram. Okay. I told you the carbohydrate count. 100 gram of cereal will give 15. 150 gives 15 plus 7.5, 22.5. That means the child is taking 22.5 gram of carbohydrate. What is 1/10 of 22.5? 2.5 or 3. That is the insulin. That is the insulin. Okay. That is the what insulin? Short acting insulin, which is going to act for 4 to 6 hours. Okay. Right. You have to maintain till evening. No. You add intermediate insulin. So double the shot. Suppose I am giving 3, give 6. So my regimen is going to be for a 3 idli, a child is taking of this much calorie, it is 3:6. Short insulin is 3, intermediate is 6. After giving insulin, then you measure, and if you are going to have 180 below, you are excellent in your management. Otherwise, every day mother will come and go 380, 250, 60, 90, 140. She gets confused, you get confused. One day it shows 150, you discharge the child. That is the problem. So that means you should be very clear in the diet and this one in a clear manner. It should be very constant. Okay. That means my style of dealing with the diabetic child is, invite the child. I am diagnosing a diabetes of 350. I will put the weight of the child. I will decide how much protein and calorie. I will divide into 6 food. The morning calorie I decide. Morning tiffin I decide. I measure my idli. I calculate the carbohydrate count. Then I calculate the insulin. I give 3 idli. I give the insulin first. Then give the 3 idli. Then measure the sugar. I will be perfect. That is the way you should manage a diabetic child. We'll go to the next. That regimen is called, short notes, insulin basal bolus regimen. That is called basal bolus regimen or insulin regimen. Okay? Okay. Now, let me go to the next department. Neurology department. You all know about the ketogenic diet. No? Ketogenic diet. This is the diet practiced for all refractive seizures, infantile spasms, myoclonic jerks. These are the babies who are treated with the ketogenic diet. Okay? So, what is the story about ketogenic diet? In 1904, one fellow called Charles in USA used to get 100 episodes of convulsions, not getting control with the 4 AEDs. Okay? His father is called John Abraham. He's a TV anchor. He heard about some trial is going on in John Hopkins University. He put his child as a trial. He is the first child to undergo trial in ketogenic diet. So he was admitted in John Hopkins University. Then ketogenic diet was started. How they start ketogenic diet? 2 days of complete carbohydrate washout. Don't give anything except little bit. Complete carbohydrate. Then you give fully fatty diet. That is the basis of ketogenic diet. What is the pathophysiology? How this ketogenic diet acts? See, when you take more of fat, what happens? Your liver is not able to metabolize all the fat. What happens? There is incomplete fatty acid oxidation. That produces ketone bodies. Your hydroxybutyrate, acetoacetate. This induced ketosis suppresses the convulsion. So, after 48 hours, they were wondering all convulsions stopped. That is the basis and origin of ketogenic diet. So they thought this is an excellent treatment for treating a severe refractory seizures. Then started on ketogenic diet for 1 month. Okay, 1 month no convulsions. Everybody is happy. But just because the child did not take protein or carbohydrate, he went in for hypoproteinemia, he went in for hypoglycemia, he even went for hypercholesterolemia. So they were worried how to deal this. Then one more scientist modified Atkins diet, ATKINS. He said, no, let us not give complete fat. Let us go for 4:1 ratio or 3:1 ratio, where 3 parts will be the lipid, 1 part will be the carbohydrate. So the child will not go for hypoglycemia, child will not go for hypoproteinemia. That is called modified Atkins diet. That is what now practiced to control refractory seizures, infantile spasm and myoclonic jag. Okay. So this is what a lot of study was going about modified Atkins diet, how to calculate. There is one thing called how to calculate. This is called calculate dietary units. Don't worry about all these calculations. Okay. What they say, suppose you take 4:1. Okay. See, 1 gram of diet will give 9 calories for fat. For protein and carbohydrate is 4 calories. That's what 4 into 9, 1 into 4. That means 40. You divide the 1000 calories divided with 40, 25 dietary units. This is called dietary unit coefficient. But don't get confused with all these answers. Suppose I am going to give 1000 calories. Decide 3:1 or 4:1. 4:1, 800 calories fat, 200 calories protein and carbohydrate. I will go to the next one. These are some of the fatty diet, heavy cream, butter, margarine, oils, some of the fatty diet. Always remember, when you want to increase the fat, it should be only through the oil, only through the ghee, or only through the butter. And of course, some non-vegetarian, I am a pure vegetarian, but still some non-vegetarian items are there that can increase your fat. That's what nowadays, stylishly some people are saying, I am on paleo diet. I am on paleo that contains more of fat, less of carbohydrate. Okay? So let me go to the next department. Surgical department, short bowel syndrome. This is the one we are not showing much interest. Unfortunately, some of the babies, they do really well. Say they do a lot of surgery for short bowel. How do you say short bowel? When more than only 40 centimeter of the intestine is available, or only 15 centimeter of the intestine with ileocecal valve is available, then it is called short bowel syndrome. That means you have removed most of the bowel because of the gangrene or NNEC. Okay. What is the plan we can do for short bowel syndrome? Okay, these are all the common causes for short bowel syndrome, where do you do surgery in removing the bowels like NNEC, malrotation and valvulus. Okay, okay. So why you should practice? See, intestinal adaptation needs nutrition. What happens when jejunum and ileum is resected? See, jejunum and ileum has got a peculiar character. The ileum will absorb vitamin B12, iron, and he will not do any job. The duodenum stomach will absorb protein, carbohydrate. But when the stomach and duodenum is not there, this ileum will take over the job of absorbing the protein. That's one of the God has created a wonder when to act. The ileum will act only on those situations. That means whenever a surgeon comes and says that this is a case of short bowel syndrome, ask one question. Sir, have you removed ileocecal valve or it is still there? It is still there, I am happy. It is not there, I am not happy. It is very difficult to plan diet for this child. Okay? So any short bowel syndrome, the first 3 days is going to be total parenteral nutrition. That will be a separate class. It's a big class. I cannot give you fully now. Then you have to go for enteral nutrition. Once the gut motility is fine, the child is able to tolerate feed, then you can go for enteral nutrition. So these are the basic principles. It should be lactose free. Many people, they avoid milk whenever in the post-operative period because lactase may not be there. So absorption may be difficult. So lactose free, complex sugars rather than simple sugars. What is complex sugar? See, I am a diabetic, no? I can take apple as a fruit. You are not diabetic. You can take as a juice. Your juice is a simple sugar. My fruit is a complex sugar. That means when I bite the apple, my sugar will go after 4 hours. For you, the sugar will rise immediately. Within this 4 hours, I run, I talk, I walk, I do a lot of expenditure. My glycemic response will. That's why you advise all diabetes, take the fruits fresh. Don't take fresh juice. You youngsters can take juice. That's called complex sugar rather than. So in the intestine, don't give simple sugar. It should be a complex sugar so that the absorption takes longer time to do. You can include protein hydrolysate and protein X and long chain. Usually any disease in nutrition, we always say give medium chain, medium chain, medium chain. This is the one condition where you have to give long chain. Can you give some oil long chain? Examples? Your gingerly oil. Okay, and your peanut oil. It's called kadala enna. Gingery oil, these are called long chain fatty acid. It takes a lot of time. Long chain means the carbon atoms are more. Short chains, medium chain is only 11. It is more than 22 or 24. That's why they say medium chain and long chain. Okay? We'll go to the next. So this is the child. We are now treating this short bowel syndrome child. His child is coming out very nicely after we are using the same principle of avoid the lactose, give complex sugar. Okay? You can see how the child is improving. The father is very happy. See the nursing the counselor also is smiling. She is also very happy. Okay. So this is what one we have taken in our nutrition. What? Then I will go to the next department. Genetics. Okay. The 3 important things. No, phenylketonuria. Phenylketonuria. In those days we thought is very difficult to treat. Now present days you can treat phenylketonuria easily also. Okay. Even though all your proteins have contained lot of phenylalanine. See what is phenylketonuria? See. A should be converted to B. For that you need enzyme. The enzyme is not there. A is accumulating. B is deficiency. My aim is don't give A, give more B. That's what the basic principles of IEM. The deficiency has to be treated. The accumulations should be treated by not giving the concerned food. If you understand this principle, A, B, then you are well versed to do good thing in inborn error of metabolism. So even though all milk contains all fluid, all phenylalanine, there are some preparations available in abroad. It's called LPFS, low phenylalanine food supplement. PHFS, protein hydrolyzed food supplement. These are the food supplement where they remove the phenylalanine. They remove the phenylalanine. Other amino acids are there. Then just remember all PG. I'll give you a clue. Any milk powder, don't worry, it is Horlicks, Bonvita, whatever the milk product, I don't want to tell the name. 100 grams of powder will give 10 to 12 grams of protein, 400 to 500 calories. This is constant. One company say 450, other company say 435, other company say 452. That's all. There's no difference. So 100 grams means 20 teaspoons will give 10 to 12 grams of protein, 400 to 500 kilocalories. So phenylketonuria can be managed. Most importantly, the level of phenylalanine is very important. You have to measure the phenylalanine. It should not cost 280 to 300. Suppose a child has got a phenylalanine of 2000, don't give breast milk for 3 days. If it is 1200, don't give breast milk for 2 days. If it is 400 to 800, give feeding, demand feeding. When the baby demands, you give. Otherwise, so you have to curtail your breast milk when the phenylalanine was quite high. Then you should know the values of some phenylalanine or low. Breast milk is So you should know the values of these are the phenylalanine value. You can see 50 million phenylalanine got 50 that is the 50 ml milk, 75 potato, 54 rice, 25 wheat, 15 cornflakes has got 50 mg of phenylalanine. My aim every day is not to cross 280 to 300. So you have to plan up to 280 to 300 if you know these values. Okay. For example, I'll ask you, out of these 5 items, which one you want to give for the phenylketonuria child? Best food. Potato, excellent. Because big potato will give less phenylalanine. So I want to give more, though that means the potato is big, no? So I like to give potato for phenylketonuria. Take mashed potato khai, potato sambar, potato, all potato you give, nothing wrong in it, okay? So you have to plan the phenylalanine level, then you should plan the diet. Next is galactosemia, okay? Only one thing, sir. IAP may say so many things. This is an IAP program, but I will tell you one thing. Start early weaning by 3 months or 4 months. Those days, Vijay Kumar sir, Srinivasan sir were giving Cerelac at the 4th month, 1960s and 70s. Now only you say exclusive, not happening. Not happening. Exclusive breastfeeding is not happening. But we say in every conference, We conduct conference, we celebrate breastfeeding week, but we are not achieving the exclusive breastfeeding. But for galactosemia, go for early weaning, because your milk cannot be given. Instead of milk, go for soya milk for 2 to 3 months or 4 months. So another 2 minutes, sir. I request you, sir. The last slide I'll go. So this is an important case, no? You see the last slide. A 37-day-old girl, vomiting since 6th day of life, frequent passage of oily stools, failure to gain weight, previous sibling has got A beta lipoproteinemia. This is the child has come to ICH, no? So A beta lipoproteinemia means what is that? There is a deficiency of apolipoprotein B48 and B100. That means absorption of fat and absorption of fat soluble vitamins cannot occur. These babies will have oily, greasy, voluminous, foul smelling, shiny smell. That is what the description for steatorrhea. You are wondering, no, why such a description for stool? Yes, that description should be there for all this fat malabsorption. Oily, voluminous, shiny, then smell, foul smelling. This is called typical description for steatorrhea. So this baby came with steatorrhea. The stool examination showed 15 to 20 fat droplets. Peripheral smell showed acanthocytosis of more than 40%, and duodenal release showed lot of fat vacuolation. So it's a definitive case of A beta lipoproteinemia. You can see this child's lipid profile. See, very unfortunate. Cholesterol 34. I think we like to have this kind of cholesterol. Yes or no? Yes, no? But this kind of diet will not reduce your cholesterol. What I am giving for the past 2-3 days, no? Right. Cholesterol 34, LDL 2, HDL 34, triglyceride 9, stool examination 8 to 10. The mother came to me. What to do? You can see the peripheral smear, acanthocytes. You can see duodenal biopsy showing a vacuolization. So a very clear case of A beta lipoproteinemia. The mother came in. This is a 37-year-old. The milk is pouring. The milk is pouring. So what I did, I called my PG. We should do something new which is not given in the textbook. Textbook says avoid fat. That's all. He says avoid fat. So what we should do? So myself and PG we decided, let us have a one gamble of this child. We called the mother. You feed only 7 minutes in this breast. 7 minutes in the breast. Don't give more than 7 minutes, so that iron milk will not be there. Iron milk will contain fat. The fore milk will not contain. But I don't want to waste the breast milk. So we continued the breastfeeding, hoping that some God will save this child. Miracle can happen. A miracle has occurred. See, after consuming fore milk of this child, you can see that length is increasing from 50 to 56. Weight is from 2.7 to 3.1. Head circumference from 34 to 36. Okay, stool 8 to 10 fat globules has come down to 2 to 3 fat globules at present. So what extra thing I should do? I should give vitamin E. Don't forget, for A beta lipoproteinemia, the one drug which can improve the fat malabsorption, vitamin E, from 50 to 500 units depending upon the age criteria, increase the vitamin E in such a way that the vitamin E can produce your apolipoproteins B48 and B100, then fat absorption slowly. So my idea, the child goes after 1 year. IMR is low, NMR is low, Modi and Amit Shah is smiling, I am also smiling. Because national indicators is fine, okay? Once the child reaches 1 year, then I can modify with the idli, dosa and other thing without fat, we can improve. That's similarly, galactosemia babies touches 1 year, he can live beautifully. If you avoid milk, he is going to be fine. Like a diabetic, no, I am avoiding sugar, he is going to avoid milk, somebody is going to avoid fat. It's easy living. It's not but the point is, up to 1 year, it's very difficult to bring this child out of the mortality. So this child was doing really well. This is the child, you can see A beta lipoproteinemia. So thanks for listening. So the final message, take home message I want to give you is, don't think nutrition is the last one, okay? Whenever I get a call from IMCU, sir, kindly call over and see this child. When I see the case sheet, I need nutrition to take the case sheet. Such a heavy case sheet, no? So unfortunately, our fellows in my own ICH, they call me for nutrition opinion once all the modalities of treatment is exhausted. So finally you want to certify. The destination has been written. Now I have to write the final journey. So for that only I have been called. But don't practice that. Even in ICU setup, day 1 you can start nutrition. If you start nutrition day 1, your mortality, your morbidity is going to come down. Thank you. He is my mentor. We fondly call him VVK. He is one of the best neonatologists I am with raising my collar, I will tell in front of the whole auditorium, whole country and whole state, I will say he is one of the best neonatologists. Whatever you read, whatever degree you get, that is different. That is different. But the dedication, the commitment which he shows, I feel no neonatologist will show. No neonatologist will show, I will say you. So he is such a person, so I am honored to get the memento from my mentor, my friend. I will not say mentor, we are just like friends. Okay, he is my teacher and he used to tell me how to practice, what are the drugs to be given, what are the drugs not to be given. We worked in almost in a nearby primary health centers. We used to discuss a lot of things while we are going in the train. So it's a long run from 1989 now, 2000, so almost 30 years partnership with Dr. Vijay Kumar.
Actually, it is my duty to acknowledge. I was just waiting for the moment to appreciate the service of Dr. Srinivasan. One message I want to give here, you would have seen, if you have to quote the book David Morley, Pediatric Practice of the Developing World, he says the pediatrician will be sitting in a chair, with the legs extended, and there's a wording below, the lone wolf waiting for the prey. That was a message that those community pediatrician, the greatest community pediatrician says. Why I am telling, our Srinivasan, whom I know for the last 8 years, taken a Dasavadara, 10 avatars, which you see the last avatar now as a nutrition expert, pediatric nutrition, but he has been his mind and soul was everything for the entire welfare of Tamil Nadu and bringing to the neonatal mortality rate. To quote a small example, I asked my friend, how do you calculate IMR? Manibardi, how do you define IMR? Who is going to tell me quickly? Others speakers are waiting. Define IMR, infant mortal rate. Who is good? Just quickly lift the hand. Please lift the hand. Yes, please get up and tell me.
Died less than 1 year divided by total number of live births.
Yes, superb. Yes, that is IMR. IMR of Tamil Nadu has come to 17 from 27. One of the great efforts of Srinivasan, because in the last 10 years he has been holding just like an opener to the last batsman in a cricket match, and he has been controlling all the 73 SNGs in Tamil Nadu. Just like you may be just thinking for 3 days he has taken so much pain, whereas he has been doing for last 10 years, monitoring, improving the service of SNG in Tamil Nadu, by which we could get it from 27 to 17. So that's the reason I want to acknowledge, because this was not mentioned on an inaugural day function here, because it was our period was different. And another thing which I want to tell again, you know what is the IMR of, we have got a Karnataka people here, what is the IMR of Karnataka? In the exam, please note MD Pediatrics, Community Pediatrics, 24. IMR of Karnataka is 24, whereas IMR of Andhra Pradesh is 32, IMR of Telangana is around 30. So it is almost so, whereas Kerala is hardly coming down to single digits. So why I am stressing that point is not only the academic knowledge and everything, but commitment to social work, the community pediatrics, which is going to which very great role in your life, for which the Dr. Srinivasan has been doing heart and soul out by encouraging the juniors like you, after passing the exam, posting the right person for the right medical college. Right, you used to sit with the counseling with the DME or DMS, and this boy is good, he is from the same place, please post him, sir. So that's how he used the coin very well, and we could achieve success. That indicates great leadership, and he has been always on call, any government of Tamil Nadu, any disaster, any crisis. You take Dharmapuri, Salem, whether it could be Rajapalayam, or Viluppuram, dengue epidemic, or Chennai, he is the first person to be called, and he used to, like youngsters like you who was totally involved, you could impress upon all the juniors, attract them, and good teamwork without asking any help from other colleagues. So he used to get very few response from some of his colleagues, and he has been managing the junior people, motivated people like you, and please continue the same zeal and enthusiasm which you have been showing even after getting your post-graduation, and that's what we learned from our great teachers, from Valgopal Raju, Dr. Pushpa, Dr. Gopal and all who are our teachers earlier, and with that we have been following, and every time we are improving upon. ஏதாவது சொல்லுவாங்க தாய் நான் 6 அடி பாய்ஞ்சினா குட்டி 16 அடி பாய்ன்ற கதை மாதிரியே everyone is doing very well. I am very happy about it. I really thank you for an opportunity. It's my pleasure to give the memento.
I request all the audience to get up and give a standing oration to all in all dedicated Dr. Srinivasan sir. Big round of applause. Keep clapping. Thank you, sir.
I think Pragala sir.